Hello, and welcome to the 8th Annual Connected Health Summit, where we focus on engaging and empowering consumers with connected health technologies and services and the innovative models changing how care is delivered. I'm Jennifer Kent, Head of Research at Parks Associates, and I'm so excited for the insights and conversations we will be exploring today. Before we get started, I know many of you are attending today are on the front lines of healthcare, and I want to recognize and thank you for the work and sacrifices that you've made in the past, year and a half during this pandemic. And I also want to take a moment to recognize our fallen soldiers and honor the ultimate sacrifice that they have made. This Connected Health Summit would not be possible without the support of our sponsors. So I'd like to give a special thank you to our sponsors, Alarm.com, Essence, and Everise, as well as our supporters, CEDIA, Connected Design, DealerScope, SCTE, the Monitoring Association, Z-Wave Alliance, Broadband Communities Magazine, ESA, Health Tech Insider, and mHealth Times. If this is your first time joining us in 2021, welcome. If you were with us for our January, April, or June events, welcome back. Today and tomorrow are special Connected Health Summit days, as we have 4 two-hour sessions across back-to-back days with 30 industry leaders allowing us to take stock of the state of the connected health space, learn from each other, and focus on next steps for this market. We'll be discussing virtual health and remote monitoring, as well as connected health business models today. And tomorrow, we'll be assessing the opportunity to serve seniors and caretakers better in living well and safely at home, as well as new investments and innovations in the future of healthcare. Then in December, please join us as we share insights on the state of interoperability and the critical work that remains to be done. In this session, I'll be sharing some of Parks Associates research from our survey of 5,000 U.S. broadband households that fielded in April of this year on the consumer experience and perspective on virtual care in the midst of a pandemic. We'll then hear from Susan Taylor, the Director of External Affairs at Scripps Health. Then my colleague Mark Vino will host an executive Q&A with Dr. David Cook, the SVP of Optum Labs at United Health Group. Then we'll invite 5 industry leaders from Northwell Health, Validic, Everise, Amwell, and Doctor on Demand to share their learnings in a full panel discussion. Finally, we invite all of you attending today and our speakers to join us in a networking discussion where we keep the conversation going and hear from you in a breakout Zoom chat. As a reminder, we invite and welcome your participation throughout all of our sessions. If you have a question for one of our speakers, please submit that in the chat or questions tab, and you'll find some polls to answer in the platform as well. So with that, I'd like to share, to set the scene for our discussions today by assessing how virtual care has changed in these past 18 months and what that means for consumers. Now, this picture is very familiar to all of us. We are more than 18 months into a global pandemic at this point, and we are in the middle of a surge that in some places in this country is the worst they've ever seen, the worst they've seen yet. And while healthcare workers have been extremely close to the effects of the pandemic throughout, it's undoubtedly become much more personal to most consumers at this point as well. As of April of this year, 72% of adults in U.S. broadband households reported that they personally knew at least one person who has had COVID-19. Because of the nature of this moment, we're dealing with an infectious disease where isolation at home is a benefit. And because of the logistical impacts of the pandemic, namely bed and staff shortages, this question is now front and center in the delivery of healthcare in a way it truly hasn't been before. Where should healthcare happen? What is the best location for care? And it's not at all obvious. It depends on an incredible number of factors. It is different for different people dealing with different conditions. And of course, the needs change as their health status changes. And there's the question of the ability to care for people well at various locations. Today, there are at least 4 main models developing for care that happens from the home, including telehealth, virtual visits, typically for checkups, primary care, urgent care type conditions, remote patient monitoring to diagnose a specific condition, often cardiac issues or sleep disorders, ongoing remote patient monitoring programs for those with chronic conditions or for a limited period of time after someone has been discharged from the hospital. And finally, a hospital at home concept that brings hospital level care into a patient's home, including not only monitoring devices, but staff to the home as well. And this last one is particularly interesting as healthcare systems take advantage of CMS's acute hospital care at home waiver, providing reimbursement for hospital level care delivered at the patient's home under certain conditions. And as of just earlier this month, August 9th, CMS counts 69 systems and 148 hospitals across 32 states that have been approved for acute hospital care at home. However, it's through the first model that the vast majority of consumers will experience virtual care, through a telehealth visit or conversation or chat service. And Park Associates data tracks the incredible growth of engagement with telehealth services over the past 2 years. In April of this year, 64% of consumers reported that they had participated in a virtual visit of some sort in the prior 12 months, up from just 15% in 2019. We're seeing similar jumps in familiarity, where 49% of adults now consider themselves highly familiar with telehealth, compared to 30% this same time last year. The appeal of telehealth services has risen, as has the likelihood that consumers will use a telehealth service the next time they or their children are sick. If we're looking for indicators that telehealth services are here to stay, our data absolutely indicates that consumers want and likely will expect telehealth to be available to them going forward. Now, one of the major shifts in the telehealth models over the past 2 years has been the route by which services are accessed and delivered. In 2019, 40% of those who had participated in a telehealth visit did so through a telehealth service with a nationwide network of doctors. This is simply not the primary delivery model today. Today, local providers, mental health specialists, local hospital systems are the primary channel for telehealth and the face of that service to consumers. And I would argue that this is a great development. In the past, our data has shown that consumers highly prefer using a telehealth service, not just to visit any doctor, but to visit with their doctor. And for many, this is now the reality. And as such, consumer willingness to use telehealth has grown exponentially. Now, one of the main limiting factors for virtual visits today is simply the amount and type of data and quality of data that can be collected via phone call or a video visit or a chat service. And it's all consumer reported, likely qualitative, subjective data. In a facility setting, clinicians have access to real-time vital sign data from the myriad of devices at hand. In a remote patient monitoring setting or hospital at home setting, these devices are provided. But what about the growing number of devices that consumers have at home? How can providers make use of that data, should they? There is no doubt that more and more consumers have connected health devices in their homes. In 2021, 55% of US broadband households report owning at least one connected health device, including devices like Wi-Fi weight scales, smart thermometers, and Wi-Fi blood pressure cuffs. It also includes connected medical devices like CPAP machines, glucometers, and pulse oximeters. It also includes wellness-focused devices like smartwatches and fitness trackers. And this is really a huge jump from Q2 of 2020. We typically do not see this type of jump in adoption in any category of products in a single year. And when we look at individual product categories, the more general purpose devices like smartwatches and weight scales definitely lead the pack. 27% of respondents report that they personally use a smartwatch, and that's a rate that is double of that just 2 years ago. Consumer-grade devices, particularly smartwatches, have been adding capabilities with each new generation that make them more functional, more valuable to the user, and of greater real help with health management. The Apple Watch is undoubtedly the best adopted and one of the most advanced smart watches in this regard. But when we consider devices from Omron, Fitbit, and others, the innovation out there is pretty incredible. Today's smartwatches offer heart rate monitoring, irregular rhythm notification, an ECG app to record symptoms as they happen, which can sometimes be hard to catch if you're relying on an in-facility model, blood pressure detection, blood oxygen detection, the ability to automatically detect falls and automatically send an SOS note or call a loved one or a professional monitoring service, monitoring of stress, medical ID for providers to be able to quickly access important health information automatically in an emergency, and physical activity monitoring like steps and fitness activity. But again, smartwatches are not the only devices consumers are interested in acquiring for their personal use or their household's use. Intentions to purchase connected weight scales, blood pressure cuffs, and thermometers have all doubled year over year. Consumers want better insight into their health, a better ability to care for their family, and they're looking for solutions to help them do so at home. This shift in consumer mindset, this jump in demand for connected health products and services absolutely impacts care providers as well. We asked consumers what impact a variety of connected health products and services would have on their decision to select care providers in the future. And 1/3 report that having the ability to share data from a connected health device with a provider would make them more likely to select that provider for themselves and their familiarity. And this jumps to over 50% among households with children. So today's discussions center on this question: what is the best location for care? Are new models of care at home up to the task? What have we learned from the last year's scaling of telehealth and virtual health capabilities and models? How are systems and vendors improving on capabilities, on processes, on staffing? What will the future of virtual care look like outside of crisis conditions? So with that, I'm so pleased to welcome Susan Taylor. She's the Director of External Affairs at Scripps Health, and she'll be talking to us about how gadgets, gizmos, and compassionate care combine to create good health. And before joining Scripps in 2012, Susan spent more than 30 years as a TV journalist on the front lines of the Persian Gulf War, covering national stories like the O.J. Simpson trial and Rodney King riots, and major natural disasters such as wildfires and earthquakes. With such an expert background in assessing and communicating the big story, I'm excited to hear Susan's perspective on the connected health story today. Hi, Susan.
Hi, good morning to all of you. Thanks so much for letting me be part of this. This is just spectacular.
Well, thank you so much for being here. We really appreciate it, and I'll hand it over to you.
Okay, sounds good. Let me just call up PowerPoint so everybody can see. All righty. Okay, everybody, let's be honest. How many of you get up in the morning and the first thing you do is check your cell phone? And how many of you get into bed at night and the last thing you do before you turn out the lights is check your cell phone, send a couple of emails, post something on Facebook, Twitter, Instagram? Can you believe that 38 years ago, cell phones did not exist? And the cost of the first cell phone was a bargain. Anybody guess the price? How much was the cost of the first cell phone? $2,800, $3,600, $5,000? Actually, it was a bargain at just $4,000. And the World Wide Web, as we know it, it really didn't exist in a cohesive way before. Anybody guess what year? Actually, it was 1989. And who developed it? No, it wasn't Al Gore. It was actually this guy. It was Tim Berners-Lee, a British scientist based in Switzerland. The World Wide Web, as it was originally designed to share info between scientists and universities and institutes around the globe. So the world has changed with lightning speed in the last 32 years. At Scripps Health, where I work in San Diego, California, we have devoted a lot of time and money to digital health, mHealth, mobile health technology. And there's no shortage of gadgets and gizmos out there. Want to talk high tech? Take a look at this. Tony Fernandez became paralyzed from the waist down after a rare cancer attacked his spine. He was bedridden for months. Now look at him. Thanks to philanthropic dollars, these $100,000 robotic legs put Tony back on his feet. In his darkest hours, Tony promised his wife, Cindy, that one day he would walk again and hold her hand. Tony is now cancer-free. And as you can see, he and Cindy are pretty happy about the road ahead. Diabetes is one of the top 3 healthcare concerns, along with heart disease and cancer. There are 28 million diabetics in the United States. By the year 2050, diabetes is going to affect 1 in 3 people. Scripps takes care of more than 27,000 diabetes patients across San Diego County and is ranked #1 in San Diego and among the best in the nation for diabetes care. We help people like Taisha. The mother of 5 slept all day long because of her out-of-control diabetes. She was in pain, she was depressed, and when she went to kiss her kids goodnight, she always said that she felt like she was dying and that each night would be the last night that she would see them. But then Taisha came to Scripps. She was enrolled in a clinical trial testing out this new device to help control her blood sugar levels in real time, giving her instant feedback no matter where she is eating, whether she's at home, out in a restaurant, at a friend's house. This device has now been approved by the FDA. And Taisha, she's lost 30 pounds.
I can be that mother to my children. I have so much energy. I have so much life. And to just be sitting here knowing that I'm about to embark on something new that can help me even more. I'm at a loss for words. They saved my life. So, thank you.
The Scripps Whittier Diabetes Institute now has a 5-year grant from the National Institutes of Health to fund an innovative clinical trial to improve type 2 diabetes management among high-risk Hispanic patients in San Diego County. Sorry, we're having problems with the microphone there. Okay, it's called the Dulce Digital Me Study. Okay, so 414 participants get personalized text messages to encourage proper eating habits, physical activity, and remind them to monitor their blood sugar level and take their medication. They also have to respond via text to questions about their diet, exercise, and stress levels. The other half of the study's participants, they get a standard one-size-fits-all message. So we're going to see which one works better, but the early results indicate that whether it is a standard text message or a personalized one, just getting the text makes patients more aware of what they're eating, and their blood sugar levels are actually coming down. Now, how about a breathalyzer to detect lung cancer in its earliest stages? There's several companies testing out devices that connect to your smartphone. It's got biosensors that sample your breath, searching for certain chemical compounds associated with lung cancer. This actually came about because of dogs, because they can actually smell the chemical changes in your breath. And obviously, you are breathing into your phone all day long. What does that mean for cancer? Early detection saves lives. At Scripps, we're replacing a traditional one-size-fits-all medicine with individualized, personalized medicine. Genomic sequencing is the window to a brave new world. Take the blood-thinning drug Plavix. People spend $10 billion a year just on Plavix. Well, it turns out it doesn't work for 1/3 of the people who take it. For them, an aspirin works better. Scripps was first in the country to come up with a simple blood test that will tell you if Plavix is working with your genetic makeup. Back in November 2016, a Scripps Health patient became the first person on the West Coast of the US to be implanted with this device. It reduces the risk of having a stroke by actually closing a small hole in the heart. Dr. Matthew Price placed the tiny device in a female patient during a 45-minute procedure. So roughly 30% of Americans have a small hole in between both sides of their heart muscle. For most people, it spontaneously closes after birth. The defect is not a problem. It doesn't require treatment. But it actually appears that this hole might play a role in certain types of strokes, allowing a blood clot to pass through the heart, travel up to the brain, where it causes a stroke. This implant is low risk. The patient is awake the entire time. Once the tip of the catheter is positioned in the hole, a pair of these mesh discs are unfolded, clasped together, and it closes the hole. In an 8-year study that paved the way for FDA approval, 499 patients ages 18 to 60 were treated with the device plus blood thinners. 481 patients only got the medication. The group that had the implant, they had a 50% reduction in the rate of new strokes compared to the folks who just got the blood thinners. Some 2.2 million people in the US have what's called AFib. This happens when electrical impulses that control the heart become erratic, and they interfere with the heart's ability to pump blood. As a result, blood can pool in the heart and actually form these blood clots. And once again, if they travel to the brain, they can cause a stroke. So a lot of people with AFib take blood thinning medication to reduce their risk of stroke, but you bruise a lot more easily with these medications, and it raises the risk of life-threatening bleeding. Enter the Watchman. So this reduces the stroke risk and possibly eliminates the need for blood thinners. Scripps Clinic has done more implants of the Watchman than any other facility in the entire US. Dr. Doug Gibson is the #1 implanter in the country. So this device is implanted into the heart without surgery. The patient is given a local anesthetic. The catheter is inserted through a small incision in the groin, threaded up through a vein to the heart. The procedure takes about 2 hours. Patients spend a night in the hospital, and then 45 days later, they can stop taking their blood thinning medication for good because the Watchman is now on duty. So you can see why US News and World Report ranks Scripps among the top 20 in the nation for heart care. This is actually not a gadget or a gizmo, but it's worth mentioning because this is a game changer. Scripps has formed a partnership with the #1 cancer center in the country, if not the world. The Scripps MD Anderson Cancer Center offers adult cancer patients across the west coast of the US, Southern California, greater access to world-renowned oncology care, including the largest number of clinical trials for cancer nationwide. And in most cases, you don't have to go to MD Anderson in Houston for those clinical trials. You can stay here on the West Coast with your family and friends and your support system. To give you some perspective, Scripps has 15,000 employees at our 5 hospitals and 29 clinics. We take care of you from head to toe. MD Anderson has 22,000 employees who deal with nothing but cancer 24 hours a day, day after day, year after year. And so together, this partnership, we will make cancer history. Now, this device is called the DynoSense. You put your finger on the sensor, you put your thumb on the silver top, and your lips on the silver, the thumb on the silver bottom, lips on the silver top. That long silver thermometer, it goes underneath your tongue, and then you blow hard and fast into it. So your finger senses the level of oxygen in the blood. For example, folks who have COPD or asthma or other lung problems, this can actually calculate your blood pressure. The thumb gives you 30 seconds of an EKG, your heartbeat, your pulse rate, to see if you have any heart rhythm problems. You don't need that big blood pressure, that cumbersome blood pressure cuff. The thermometer checks your temperature. This allows you to track day-to-day changes and abnormalities. So lots of times people go to the doctor and their blood pressure is elevated. Why? Because they're nervous going to see the doctor. But aren't you also stressed out driving 3 kids to soccer and piano, dance while rushing to get dinner ready when you're late getting home from work? Or maybe the stress that's been associated from all of the COVID quarantine. This actually allows your doctor to monitor you in real time without having to go to the doctor's office. And the doctor can see how these devices occur day to day versus one time 6 months ago at your last doctor visit. This is particularly good for folks with high blood pressure. The #1 risk factor for the highest death rate is high blood pressure. It's more than smoking and diabetes. Roughly 30% of people in the US don't know that they have high blood pressure because there's no symptoms, but they are at risk for a heart attack or stroke. So this device was approved by the FDA back in 2019. So folks using the DynoSense will now be able to get an accurate read in real time outside of the doctor's office. This allows the patient to take control of their health. The data is also shown to the patient on their phone so they can see the trends. How about a robot to help with your knee surgery? This adds an extra layer of pre-surgical planning and improved precision down to the millimeter for partial and total knee replacements. It allows for the creation of a highly individualized plan based on the unique shape and motion of a patient's knee. Then there is a robot to help with your spinal surgery. This robot aids surgeons with 3D software modeling, planning, and guided placement of surgical implants. Robotic spinal surgeries actually take less time. They are minimally invasive, which is great for the patient because it actually speeds up the healing process. The smaller the incision, the less time you're in the operating room under anesthesia, the faster your recovery, and the robot is obviously very precise and can move in all kinds of ways that your wrists cannot. there is much greater dexterity. Now, this is the CardioMEMS. It was the first FDA-approved heart failure monitoring device. A dime-sized sensor is implanted in the artery during a non-surgical procedure. It measures pressure in the artery. Increased pressure is often one of the first signs of worsening heart failure. Heart failure occurs when pressure inside the heart increases. You get the shortness of breath and the swelling in your ankles and legs. 670,000 new heart failure cases are diagnosed every year. This breakthrough technology keeps heart failure patients out of the hospital, improving their quality of life. CardioMEMS allows us to continuously monitor patients and detect how they are responding to medication and lifestyle changes. Dr. Thomas Haywood and his colleagues at Scripps were first in San Diego County to implant the CardioMEMS after it was approved by the FDA. So this sensor lasts a lifetime. It's powered by radio frequency energy. Look at how tiny it is. It's basically the size of a dime. Once implanted, the wireless device sends pressure readings to an external electronic system. The patient feels nothing while this is going on, no sensation during the readings, which take a couple of minutes in the comfort of the patient's home. Data from a clinical trial showed that the device reduces hospital readmissions from heart failure up to 37%. We can monitor the patient at home, and that's much better for this person. Then there's the LVAD. This is for patients with a severely failing heart. It helps pump blood through the body. For some patients, it actually becomes their lifeline and can restore a healthy and productive lifestyle. It can also buy patients time until a heart transplant becomes available. Patients like Darla Calvé, she received an LVAD back in 2014. Her new donor heart, it came in March of 2015. Talk about baseball great, Hall of Famer Rod Carew from the Minnesota Twins and the California Angels. He had a heart attack in Orange County back in 2015 while playing golf. Rod came to Scripps. He got the LVAD until a donor heart became available a year later, ironically by former Baltimore Ravens tight end Conrad Royland, who had attended middle school with Rod Carew's children. Conrad passed away at the age of 29 from a brain aneurysm, but he gave Rod Carew a second chance at life.
We became doctors to see patients that have problems and to make them better. And what better experience than to take somebody who's dying and give them their life back, so that a child has their father, or a daughter has their mother, or a wife has her husband. That's really what it's all about.
Scripps is involved in stem cell research, cartilage cells to help arthritis, stem cells into the heart to regenerate a damaged heart muscle. And who knew that a 3D printer could revolutionize healthcare? Dr. Daryl DeLima, who heads up orthopedic research at the Shiley Center for Orthopedic Research and Education at Scripps Clinic, is working on using stem cells and 3D printers to assemble living tissue. Sounds like science fiction, but within a couple of years, Dr. DeLima wants to have a 3D printer in the operating room and using stem cells be able to custom print new cartilage directly into the body layer by layer to replace tissue that is missing because of injury or arthritis. So you think about this. Using stem cells and 3D printers, replacing cartilage so you will not have to undergo surgery for a total knee replacement. Less trauma to the body, faster healing, much less expensive. Check out this wild ultrasound for your heart. The traditional echocardiogram in the hospital can cost up to a couple of $100,000, and it takes 45 minutes to do the study. This V-scan sits on your smartphone. It costs just $8,000. And the study, it actually takes a minute, so your doctor can show it to you in real time. It's portable. It goes anywhere your doctor goes. According to the American Journal of Cardiology, these handheld ultrasounds detect 53% more heart abnormalities than traditional stethoscopes. Now, this device checks your heartbeat, snaps right onto your smartphone, pops right up there on your screen. You know, you'll be able to send it anywhere. You'll be able to show it to your friends or your grandkids. You can post it on Facebook if you want. Or more importantly, send it to your cardiologist's office. So if you're lightheaded or dizzy, it will give your doctor real-time, rapid real-time information. In fact, one of our doctors was on a cross-country flight, and a man was having symptoms of a heart attack. And there was on the PA system, is there a doctor on the plane? So three surgeons and cardiologists go to the back of the plane. They think that the man is having a heart attack, but sometimes indigestion mimics a heart attack. And they weren't 100% sure. Well, the Scripps cardiologist, he goes back to his seat. He gets his device from his briefcase. He puts it up to the man's chest. They see, in fact, that he is having a full-blown heart attack. They make an emergency landing, take the man off the plane, and they save his life. We're going to just have our cardiologist flying around the country from here on out. We help folks like Switzerland's speed skiing champion, Philippe May. Philippe was one of only 5 men in the world to roar down the mountain going 156 miles an hour. So when Philippe was just 6 years old, his dad and uncle both died suddenly in their early 40s within 3 days of each other. No symptoms, no warning, most likely from a heart attack. Philippe came to Scripps after arriving in San Diego to compete in a grueling bike race, the race across America, nonstop from San Diego to the East Coast. He arrived here lightheaded and dizzy. Scripps cardiologist Dr. John Rogers found that Philippe had a genetic abnormality called ARVD, most likely the same thing that killed Philippe's dad and uncle. So Dr. Rogers implanted a tiny defibrillator into Philippe's chest and can now monitor Philippe no matter where he is in the world. If Philippe's heart stops, the defibrillator kicks in and gets his heart beating again. So Philippe put his plans on hold while Dr. Rogers remotely monitored his heart from San Diego, but he came roaring back, becoming the 2015 Swiss speed skiing champion again. And then Philippe decided to top that off by hiking up 19,000 feet to the top of Mount Kilimanjaro, with Scripps monitoring his heart all the way right there on Dr. Rogers' cell phone.
Something that is monitoring my heart 24 hours a day, and it's just a little box inside my muscle. It's good.
I'd like to thank Scripps as well as Dr. Rogers for saving Philippe's life and also saving his way of life and giving us the opportunity to have a future together.
Philippe is going to compete again because that's who he is. It's the only way he knows how to live his life, and that's full speed ahead. In fact, in April of 2017, he placed first again at the World Cup Speed Skiing Championships in Europe. He set a course record. He was zooming down the mountain at 125 miles an hour, and he has competed every year since. And at Scripps, that's what we want for all of our patients. We want to help them live the life that they want. Now, all of these gadgets are great as long as the patients use them and are not stressed out by them. But gadgets alone don't make for great patient care. At Scripps, we have also implemented some pretty low-tech but highly compassionate, patient-centric ways to take care of you. Take Scripps Health Express, 16 walk-in clinics spread out all over San Diego County. You don't need an appointment, you just walk in. They're open extended hours because seriously, who gets sick between 9 a.m. and 5 p.m.? The Scripps Health Express clinics are open Monday through Friday, 7 a.m. to 9 p.m. So you can go before or after work or school. They're open on the weekends, on Saturdays and Sundays from 8 a.m. to 5 p.m. We accept most insurance plans. You don't even have to be a Scripps patient. You can come in and pay cash. And so let's say you have a sore throat, an earache, a urinary tract infection, flu-like symptoms, bug bites, skin conditions, minor cuts for burns and wounds. You need a vaccination for the flu or tetanus, HPV. Kids ages 12 and up can get camp and sports physicals. It's all available at Scripps Health Express, 7 days a week. Healthcare when you want it. Now, during COVID, we've had a tremendous amount of virtual care visits. We've had more than 500,000 virtual visits during COVID, 71% of the total volume. The highest number of virtual visits were for diabetes and endocrinology, but we also saw patients for internal medicine, integrative medicine, gastrointestinal. Many of our patients, our virtual visits were senior patients because they were worried about leaving home. What's interesting is that the 71% of the total volume during COVID was virtual visits. It's now dropped to 25%, but we're still doing roughly 1,900 virtual visits a day. So this technology is here to stay. We're also creating what we call model units across the system. We're looking at ways to improve patient care in the hospital. For example, nurses were spending too much time transporting patients, helping them to the bathroom, bathing them, feeding them. So we hired other folks to do that, those jobs, so the nurses can actually spend more time at the bedside using their training and medical expertise to care for patients. We're working with doctors, helping them talk to patients without using medical jargon. So using words that the patient understands. So for example, I always talk about the word hypertension. Patients don't really understand what that means. Another example, how about high blood pressure, which means the same thing. The patient understands, your blood pressure's through the roof or it's dangerously low. Another example is the word ambulatory. When you use that word, many people think that you're actually going to be put in an ambulance. Ambulatory means that you were up and running. So why not just say that to the patient? You're not going to be in bed after surgery. You're going to be up and walking. And when doctors stop looking at the computer and start looking at the patient in the eye and talk to them in a language that they understand, patients feel that they're being listened to. And the studies show that they comply more with what the doctor asks them to do. We've also challenged our frontline staff to do one thing different to enhance the patient experience. For example, one of the guys who transports patients to the operating room for surgery, the last thing he does before he says goodbye to them, he looks the patient in the eye, he touches their shoulder, and he says, "You're in really good hands." He says he can literally feel the patients relax as he touches their shoulder and utters those words. That kind of compassionate care is what prompted me to give up my 30-year career as a TV news anchor and come to work for Scripps. And it started with the phrase, "Have a nice surgery." The last words my 9-year-old son said to his grandpa, my dad, in December of 2008. Our family had gathered at a local Italian restaurant for one last meal before Dad's open heart surgery at Scripps Memorial Hospital in La Jolla, California. Dad's aortic valve was on its way out. He had no choice. He had to have this surgery. So as they wheeled him into the OR, I looked at him and I echoed my son's words, "Have a nice surgery." The surgery went well. The new aortic valve was working perfectly. It was humming along, doing its thing. But the complications from surgery were not so nice. For some reason, both sides of Dad's heart were not in sync. The left side of the heart was squeezing too strongly. The right side was very weak. One minute his blood pressure was through the roof. The next minute it was dangerously low. Fluid was backing up and leaking out everywhere. His entire body was swollen. He looked like the Pillsbury Doughboy. And this is the biggie. They could not close his chest. When open heart surgery is done, the last thing the surgeon does is knits the sternum, the chest bones back together with wires, and then pulls the skin over to close the chest. Well, when they tried to do that with Dad, it put too much pressure on his lungs and he started crashing. Dad was on the operating room table for almost 48 hours, too unstable to move. This is not a good place to be for that long a period of time. All kinds of things can go wrong. Skin breakdown, infection, the kidneys or the lungs fail. There's always the possibility of blood clots or a stroke. But none of that happened. So Dad's surgeon decided to leave the chest open, a little half-inch gap. You couldn't see anything. It was covered by a sterile bandage. It wasn't grotesque. How do I know this? Because while Dad was still in the OR in a medically induced coma, to our surprise, a nurse came out and asked us if we wanted to go in and see him. I thought that this was incredibly bold and very kind. So we put on sterile surgical gowns and we went in. We got close enough to see that he was peaceful and in no pain. 2 days later, Dad was finally moved into the CCU. He stayed in that coma on a breathing tube with that little half-inch gap for almost 2 months, while 80 phenomenal people in CCU at Scripps, doctors, nurses, therapists, lab technicians, receptionists, caseworkers, they worked 24 hours a day, 7 days a week to keep him alive. Talk about compassionate care. They let us bring in family pictures. They let us hang them around the room. They even let us bring in Dad's iPod. I will forever have etched in my memory the sounds of Dad's favorite composers, Beethoven, Mahler, Rachmaninoff, enveloping him, punctuated by the low beeping sounds of all of those machines that he was hooked up to. Periodically, our son would ask to see his grandpa. My husband and I had said, no, Grandpa was in a deep sleep. But about 6 weeks into it, that sweet little 9-year-old boy, he put his hands on his hips and he said, Mom, my grandpa needs to see me. And in yet another bold act of kindness, Scripps let us wrap up our son in a sterile gown. And I will forever have etched in my memory the image of that precious boy holding his grandpa's hand. Slowly, Dad began to recover. Both sides of the heart started to squeeze and sink, thanks to the heroic efforts of his cardiologist, who stayed up many nights trying to figure out the magic combination of drugs to help the left side of Dad's heart squeeze less vigorously while nudging the right heart to strengthen. But what to do with that half-inch gap? Well, what they did was they took Dad's right pectoral muscle and his left rectus muscle down by the rib cage, and they pulled those two muscles into place, fashioning a flap to cover the heart and fill in that gap between the bones. And then we all held our breath as Dad's surgeon closed the skin over the chest. Every night I would send out a mass email to family and friends, bringing them up to date. One night I got an email back from my cousin in New York. She had been at a cocktail party and she was retelling this wild story about Dad. And one of the people interrupted her, a doctor, in fact, who said, "Oh, that must be Scripps. They're known for that kind of innovation." It's my understanding this kind of surgery is very rare. It is the Hail Mary pass of heart surgery. It's what you do when there is nothing else left to do. My father was operated on December 4th, 2008. Once they brought him out of the medically induced coma in late January, he took his sweet time to awaken, about a week. And only then did we confirm no brain damage. In February of 2009, Dad was transferred to Scripps Encinitas to that hospital's rehabilitation wing. When you're laid out for so long, the body loses 2% of its muscle mass every day. You do the math. When Dad entered rehab, he was like a 2-month-old baby, having to learn to do everything again, retraining the muscles so that he could move his neck, lift his head, roll from side to side, relearn how to sit, stand, grasp, and swallow. Dad was on a feeding tube for 4.5 months, and when he finally passed his swallowing test, the voice and swallowing coach asked him, "So, what do you want to eat?" His reply, "Costco hot dog." And you know what? No one asked her to, but she went to Costco and she got it for him. We celebrated Dad's 80th birthday at Scripps Encinitas. They let us throw a party in their outdoor healing garden. They even let Dad have a little chocolate mousse. On July 3rd, 2009, 1 day shy of 7 months, we celebrated Dad's independence. We finally took him home. Now, this was an incredibly challenging case, and Scripps did everything right. Now, in the beginning, I thought a little cynically that Dad was getting exceptional care because I was on television. I came to realize after walking the halls of Scripps at all hours of the day and night that everybody who enters those doors gets treated the same way, with a smile and a hug, a sense of grace and dignity and humanity, a profound sensitivity to the patient and their family, because that is the Scripps way. For the 2.5 months that my dad was in a coma, I would go be with him in the morning. Then I would rush to NBC and anchor the 4, 4:35, and 6 p.m. shows. Then I would rush home to see my husband and son for dinner. Then I would rush back to check on Dad. Then I would go back and anchor the 11 p.m. news. And then I would go back to the hospital at midnight to check on Dad. And who was still there at midnight? His heart surgeon. And the two of us would sit there, nobody else around. And we would talk about life and death and beating the odds. The odds are never good enough. And during one of those late night talks, I remember asking the surgeon how many other times he had left the chest open in his 30+ year career. I said, "What happened?" He said, "Actually, only 2 other times." I said, "What happened to those other people?" He said, "Sadly, they both passed away, because by now, in most cases, there is either massive infection or one of the other organs, the liver, the kidneys, the lungs, start to fail. But in my dad's case, none of that happened. And so the surgeon said he would keep going, trying to find a way to help Dad heal and bring him out of that coma. But if things took a turn for the worse, the surgeon looked at me and he said, 'I will not flog a corpse,' meaning that he would not put my father through any unnecessary tests and procedures if the outcome was not going to be good." And so with all the technology out there that was available then, and even more of the technology today that's available, I remember that conversation so vividly. I remember thinking how kind he was, and that one-on-one eye contact between the two of us. It meant as much to me as all the technology that was being used to keep Dad alive. My father lived another 7 years before Parkinson's disease took his life in 2015. He had 7 more years to hold Mom's hand and watch his grandson grow up. The CCU staff calls my dad their miracle man. but it is the folks at Scripps who are the miracle workers. I remember emceeing an event, and a woman came up to me and said, "Do you remember me? We spent a lot of time together in the CCU waiting room when your dad was in the hospital." I thought for a minute, got real quiet, and nodded. Her son had been in a coma with a traumatic brain injury. I looked at her. Dare I ask? She smiled and said, "On Christmas Day, my son opened his eyes." I started to cry. Then, as I still get choked up now, I said, "Okay, dare I ask now, how is he 3 years later?" She smiled and said, "He's married, and in 3 weeks, I'm going to be grandma." At Scripps, we treat more than 700 people a year, and we have a story for each and every one of them. Most not quite so dramatic, but each of them just as important. I feel fortunate now to be part of the solution. I'm invigorated to go to work every day, to be surrounded by brilliant, compassionate people who value quality, innovation, dignity, and humanity, who put the patient front and center of everything we do. Yes, we have incredible technology, but equally important, we have spectacular doctors and nurses, and a culture that treats patients like family, not just the patients whose daughter happened to be on TV. So for my money, I want all the latest technology that's available, but I also want something very low tech. I want the doctor or the nurse to stop and look me in the eye when they're about to give me good news or deliver bad news. It's compassionate care that is so incredibly important, critically important, when you are critically ill and feeling incredibly vulnerable. So there's a lot of gadgets and gizmos out there, right? How many of you have an app on your phone that tells you how many steps you take each day? Let's see. How many steps have I taken today? Let's see. I've taken not very many. Oh, only 212 steps. Yeah, but here's the thing. What if I do this? You know, what if I tap this? If I tap this on my body, oh, all of a sudden I've gone up to 226 steps. So look, this app doesn't really help me. I'm only cheating myself, right? So let's face it, a gadget might look cool and do sparkly things, but at Scripps, you know, these gadgets may be entertaining, but at Scripps, whatever we use has to improve your life. It has to help you sleep better, lower your cholesterol, blood pressure, detect cancer earlier, because we're all going to live to be 100, right? And don't we all want to live rather than just exist? So for us, gadgets and gizmos may look cool, but they also need to meet the burden of proof. They need to lead to that third G. Gadgets, gizmos, and compassionate care equals good health. Think about that tonight before you say goodnight to your cell phone. Thank you.
Susan, thank you so much for that, not only kind of tour of innovation of what Scripps is doing and all of these different, you know, scenarios for different types of patients, but also reminding us of that human touch and how important, you know, the humans in the system are as well.
Yes. Thank you.
Well, we are at time. We do need to move to our executive Q&A. We have a couple of specific questions that came in for you related to some of the programs that you're working on. So I'm going to go ahead and shepherd those to you kind of on the side in case you'd like to respond to those participants today. Next, I'm so pleased to welcome my colleague Mark Vina, who will host a conversation with Dr. David Cook, who's the SVP of Optum Labs.
I do have a question from the audience. How do you see working with utilities as a channel to increase smart home adoption?
Got the panel's perspective, the builder's perspective. Now let's see what the audience was thinking. How big a challenge is interoperability?
Someone submitted a question. What is the take for managed Wi-Fi services?
I'd like to divert from my next question to one of our audience questions. What type of content do you feel most likely to provide MVP subscription and retention?
We did have a question in from our audience though, so let me jump over here real quick. Have you or are you thinking about solutions around employee privacy?
We have a lot of questions coming in. I kind of want to dovetail on one of them. Can you talk about how you kind of view the pay TV business model?
Just a reminder to our attendees, you are able to ask questions in the live discussion button. You should bring up a paddle, and there's a Q&A tab.
Good afternoon. My name is Mark Vina. I'm the Senior Director of the Smart Home and Research Practice at Parks Associates. here for today's Q&A. I'm very excited to introduce Dr. David Cook. We're very, very fortunate to have him. David is the SVP of Optum Labs at United Healthcare, the United Healthcare Group. He's an internationally known physician leader with broad clinical, administrative, financial, and operational experience with over 20 years at the Mayo Clinic. So this is obviously a gentleman that is great to talk to about some of the various topics we want to explore. So with that, let me bring up Dr. Cook. Dr. Cook, welcome to the webinar.
Mark, thank you for having me. It's a pleasure to be here.
Yeah, I have so many questions for you, Dr. Cook, so many questions. But, first and foremost, only because they're in the news all the time, we're always talking about wearables. We're always talking about the impact of those devices on connected health. When you look at it at a high level, the role of the tech giants, and there's not just Apple, of course, there's many, many other companies. What do you believe is their role in the connected health space? Can you give me some color on that?
Yeah, I'm happy to. I think if you look at the Apple ad that came out a few months ago for its watch, the title of the ad was "The Future of Health," and I think clearly separating health and healthcare are absolutely critical. The advertisement essentially shows how technology maybe can help move a 29-year-old woman from being sedentary to a triathlete. And I believe that really is the future of health, because health is established over a lifetime, but that's really different from healthcare. And I think a lot of us here in the audience and elsewhere are really, really focused on healthcare. The tech giants, we have to learn from. The tech giants really understand consumers probably in ways that providers don't. They understand consumers in the way that payers don't. The tech giants will help inform the public. They're going to enable the public to do things that they've never been able to do. And probably most importantly, they're going to be able to engage the public in ways to support health. They're also going to have a role in healthcare, but that's going to look a lot different from health promotion. Mm-hmm. And maybe if we talk about security later on, we can talk about the role of big tech in information security.
Now, what's interesting, and Parks has got some terrific data on this, is that we can really quantitatively point to the fact that COVID-19 really has been a tremendous tailwind for telemedicine and telehealth. I mean, we're seeing some staggering numbers. 64% report using a healthcare service in 2021. 66% have had some type of healthcare consult in some way, shape, or form. I guess the question is as we kind of look forward, down the road, do you believe that will we live in a world at some point where those numbers are in the upper 90s, where that's a routine thing to do? Instead of getting in your car and going to see your doctor, you're going to do this as a default, from a virtual standpoint. So what's your perspective on that?
So if anything good happened out of the COVID pandemic, it's probably the acceleration of telehealth. Mm-hmm. This country has always had barriers to access. The health demands of the population exceed what really can be delivered through kind of traditional brick and mortar. This genie is out of the bottle. Thank goodness it's not going back. Mm-hmm. The issues that really have to be defined are for whom is telehealth the best solution? For what kinds of conditions is it the best kind of solution? And it's going to really vary. When we look at our own UHG data, we see huge differences in the application of telehealth between different kinds of populations and across different health conditions. For example, when we looked at telehealth services for people receiving cancer care, the impact is minimal. But if you look at things like diabetes or hypertension care or behavioral health, the opportunities are extraordinary. The other thing that's going to have to sort itself out over time is what are going to be provider and patient preferences. we have to account for and address patient and provider preferences, because in the absence of that, our delivery model won't be successful. So telehealth has fallen off, as has been identified previously, and we don't know whether it's fallen off because of providers wanting to go back to brick and mortar or patients wanting to go back in brick and mortar. But we really have to understand the evolution of preferences over time. It's another thing that health big tech can help us with.
But you sound very optimistic in that you think those numbers will probably go up from now, correct?
Those numbers are good. Yeah, I'm confident that those numbers are going to go up. Really, if you think about it, the chronic disease that burden that this country faces and the world faces, these are the kinds of conditions that require really high frequency touch. Because they're largely, a lot of them are behavioral in origin, whether it's diabetes or hypertension. These things take years to develop. We're going to manage these with high touch solutions, but they're going to be high touch, low acuity solutions. And telehealth is ultimately going to be the way that we deliver that kind of care at scale.
What I'd like to ask next is that there's a brand new concept, relatively new, this hospital at home concept versus traditional remote patient monitoring. First question, part A is, could you explain for the audience the differences in between those conceptual models? And then how is Optum Labs engaging in this new hospital at home model?
Well, if you look at the CMS requirements around hospital at home, they're really pretty rigorous. Mm-hmm. It's been a while since I looked at them, but these services are only suitable to patients being discharged from a hospital bed or from the ER. Before they're implemented, they always begin with a provider visit. I think the requirements are 3 or 4 visits a day as a minimum. And if you look at the couple of hundred organizations that have moved into this space, there are really a lot of the leading academic and healthcare systems in the U.S. So the infrastructure requirements to truly do hospital at home, as it has been outlined by CMS, is really demanding. And I think the application of that, at least given the way the rules are, is going to be really limited to large systems that have deep infrastructure that can manage patients 24 hours a day. I mean, hospital at home regs require that the provider system be able to respond to any patient within 30 minutes, 24 hours a day. So these are big demands. I think it's important not to conflate hospital at home with the kinds of services that will extend and allow for independent living. This is something that is a real priority for United Healthcare, for Optum Labs, really for the country as a whole. And so, making sure we don't sort of confabulate hospital at home with the kinds of services that can support people in their home longitudinally are going to be important ones. And certainly all of our Optum Care entities taking care of high-risk patients are sort of moving into this space slowly. But because the infrastructure requirements are so great and the technology requirements are great, it's probably in a lot of ways going to have to be a shared services model where you have large central hubs that can manage patients rather than having to replicate these at multiple sites.
But the hospital home play and the services associated with that, they are really designed ultimately to enhance a high quality independent living situation, correct? This is not, you're trading things off. So I want to talk a little bit about that because I think that's really important, because at the end of the day, what this is all about is enhancing quality of life. So can you give us a little bit of color of that related to the services that typically would be involved in the hospital at home situation?
Well, I'm actually kind of more interested because hospital at home is really pretty intensive.
Yeah.
It would typically involve, a variety of remote monitoring. It's got the telecommunications requirements are robust. we've got a program that uses Vivify. It's got multiple different sorts of integrations of technology, blood pressure, heart rate, pulse oximetry. It lays out longitudinal plans of care that the patients interact with. There's providers available all of the time. But these are still relatively heavy solutions. And the barrier is almost never the technology. The barrier is almost always the back end, because the people requirements and the monitoring requirements to be able to take care of patients 24/7 are really, really pretty demanding. And as I look at this space, and other sort of thought leaders at Optum and UHG look at this space, we really think about what are the kinds of technologies that sort of are easier to implement, applicable to hundreds of thousands or millions of people, and don't have such either tech or personnel heavy back ends. And so as for any of these services, you have to think about ultimately, what is the acuity of the problem that you have to solve? Be really, really specific about the problem set that the technology needs to deal with, because the problem then defines the data requirements. The data requirements in turn help inform the sort of decision support that lays on top of that, and then that determines the infrastructure requirements. A lot of technology companies come to me in my role in Optum and Ventures and say, hey, listen, we've got this great new tech. I want you to look at it, and what do you think? And most of the time, my response is, I'm going to trust you've got good engineering. I'm not worried about the engineering part. I want you to show me how you separate signal from noise. I want to have you show me how you start to enable providers, how you integrate with workflow. And I start with those things, because if those haven't been worked through, then it doesn't matter how good the engineering is.
Oh, I want to flip the conversation back to the whole wearables topic, because it's such a hot topic, and it has been for quite some time. Wearables are now becoming the best adopted connected healthcare device in the U.S. And of course, Apple Watch kind of leads the charge there. But the question I want to ask you, and it's kind of a little bit of try to get your kind of going forward view on this. Do you see a collision coming between wearable devices and consumer grade health devices, and even bona fide commercial medical devices? Is there a convert? I mean, a lot of those capabilities are coming together in the same device, but from a healthcare standpoint, making sure these devices are generating information that is valuable, it's accurate, it's predictable, so it can be utilized properly. Do you see those kind of categories coming together at some point?
Yeah, I certainly do. It ultimately has to be, well, again, to sort of repeat what I said before, the data that's incoming has to address the problem that you're trying to solve. And it's relatively easy to throw wearables at a problem, but somehow it has to be translated into value. And just putting wearables on is not really enough. You've got to really clearly define the problem that you're trying to solve. Make sure that the data that comes in at the right sort of frequency. Again, that you've got the back end to deal with it, and ultimately, it's going to support decision making. There's going to be a collision, I think, because the consumer space around wearables and health tech, frankly, is moving faster than our typical health system's ability to consume it and make it usable. As long as it's not usable for providers, providers are going to they're going to have at least somewhat of an immune reaction, because a patient may come in with, reams and reams and reams, equivalent of reams and reams of data, and say, well, doc, what do you think of this? And in a 15-minute primary care visit, there's no way to do that. So until those sorts of technologies can start to find some ways of integrating to support decision making at the point of the care, they're going to be a struggle to use. The exceptions are going to be technologies that don't really require super acute decision making. So things like fall monitoring is going to be important. We may get to this later, but I like CGM. We're working with CGMs really pretty broadly here at Optum Labs and at UHG. There are going to be other monitors that are going to come into existence that don't exist yet. And for the technologists out there, one of the ones I'm looking for is a assessment of hydration status. The nice thing about something like that is it's not going to generate an acute event. We can potentially follow an older person's hydration status over days. That gives us adequate response times to start to deal with it. Another sense of technologies which exist but aren't being applied in this way is I want to know how much time someone is horizontal versus how much is vertical, right? That, and be able to look for trends in that. And the nice thing about that data, again, is it doesn't require 24/7 back end, and it doesn't necessarily have to be tech heavy. So those applications sort of go back to keeping people healthy in the home. They are relatively simple data solutions that don't require heavy back ends and have broad applications in populations.
So, just to kind of wrap a bow on this, I mean, down the road, I'm assuming that you believe that really wearable devices, especially as they get more sophisticated and more capability, as you've suggested, that they are ultimately the solution for lowering long-term healthcare costs, lowering premiums. I mean, that has to be the business consequence out of this, I assume.
Yeah, I mean, ultimately, those have to be translated into value, right? We just somehow, I sit with both the provider hat on. I was at Mayo for 20 years. Now I work for United Health Group. They just have to translate into value. It's not enough to say, hey, listen, we can acquire this data, right? The technology needs to demonstrate how it makes a difference in value. It will happen. We may find that there is some segregation. Some of that data may end up being cloud-based and partly independent of providers and reachable through APIs that can pull that data down, so you don't have to do quite so many EMR integrations.
I want to ask you one last question, then we're going to go into some Q&A that we're getting. I guess, one of the questions I do want to ask you, because it is an important one, is the role of privacy. This is all wonderful technology. It's disrupting healthcare in so many different ways and has, of course, the ability to improve people's lives. What's your view on, and I'm putting you on the spot a bit, Doctor, in terms of the big players, the Apples, the Googles, the Amazons of the world? Who do you believe, I mean, you maybe have to give a qualified answer, who has really the best or the most appropriate privacy strategy from your perspective?
I'm going to answer this question a different way. In last year, there were more than 600 large healthcare data breaches affecting 22 million Americans. There was a survey done, I think it was in 2019, that said healthcare were ranked 8th in its data security. Healthcare systems, frankly, really fail in data security. And players like Amazon and Google and Facebook really have the best data security in the world.
Okay, I'm going to read the next. That's a customer.
So I think we're going to increasingly rely on those companies to increasingly to host our data, because we in healthcare are not doing a very good job of it. The number of breaches that occur because the internal practices of an organization aren't secure are just enormous. So, or healthcare organizations in the U.S. are failing here, and I don't think it really matters whether it's Azure, Microsoft, or Google is doing this for us. This is where we're headed.
Well, let's tee up, Doctor, our first question from the audience. I'd love to get your view on this. What is the role for insurance companies with connected devices? What is it, from an insurance point of view, to help them stay healthy? What is the role for these insurance companies as we kind of get into this brave new world?
Well, once value is demonstrated, ultimately the insurance company is going to be the payer for the applications of the technology. For many of these technologies, or really almost all of these technologies, to really find their place in the marketplace, we're going to have to move progressively to value-based models, because it's really in value-based models where these technologies will ultimately make care more efficient and reduce cost of care. So figuring out how to work these technologies into organizations like ACOs that are really focused on value-based payment is the way that they're going to get paid for by payers.
Next question. Optum Labs has a program that focuses on Alzheimer's and dementia detection. What do you see, Dr. Cook, as the compelling applications of health tech and virtual care services for seniors specifically in those two areas?
We are moving into this space in important ways. Alzheimer's disease and dementia is diagnosed too late in the primary care office. It sort of is relatively quiet. It's partly clinically silent, but it expresses itself in the home and in daily living. So we're going to start using a variety of analytic models, using natural language processing to try to understand features of clinical notes or even of social media or things like reaction times that will allow us to start to identify subclinical cognitive changes. And we're confident that over the coming years, that technology is going to allow us to identify those changes earlier and start to intervene to promote cognitive health before significant declines occur.
Well, Dr. Cook, thank you again for spending so much great time with us today. We really appreciate it. Next up, we have a panel discussion with Jennifer Kent, but please stay tuned and we will be right back.
Great, thanks, Mark, and great conversation with Dr. Cook there. We are excited to move into our panel discussion about lessons learned and next steps in virtual care. I'm joined by industry experts from a variety of different companies that work across the virtual care space to really bring their expert perspective to what they've seen and learned over the past 18 months. So what I'd like to do is invite them each in to tell you a little bit about themselves and about their organization. So first, I'd like to introduce Iris Berman, who's the VP of Telehealth Services at Northwell Health. Hi, Iris.
Hi there, how are you? Thank you for this opportunity. For those of you who may not know, Northwell Health is one of the largest health systems. It is the largest health system in New York State. It's a nonprofit. We have 16 acute care hospitals, a total of 23 if you include all of our behavioral health facilities. We serve over 7,000 providers. And I say serve because that became very evident during the pandemic, that we also had to serve our providers, not just our patients. We're very large, and we cover downstate New York, all of Long Island, Manhattan, Westchester, and Staten Island. So we have a fairly far reach and a little bit into Connecticut. That scenario played out hugely during the pandemic. And so our telehealth services started as a very small department in 2014 and blew up over the last few years. In particular, the silver lining in some strange ways was COVID. So I'm looking forward to talking about some of that and some of the innovation and things we've learned today.
Wonderful. Thank you, Iris. Appreciate you joining us, and we're looking forward to hearing those insights. Next, we have Brian Carter, who's the Chief Operating Officer of Validic. Hi, Brian.
Hi, thanks for having me today. Yeah, again, I'm Chief Operating Officer with Validic. Been in the healthcare IT industry for about 21 years now. I'm an engineer by background, but I've really spent probably the better part of the last decade and a half running product strategy for patient engagement and digital health solutions. I've been with Validic now for almost 4 years, and Validic was founded in 2010 with the mission to really connect people and their care teams through technology so that we can get timely insights and support the management of chronic conditions, post-acute support, promoting health and wellness. And we're really privileged to be working with a lot of the country's top payers and health systems, servicing about 5 million people at this point with billions of data points and touch points every year. Thanks again for having me.
Great, thank you, Brian. And next up, we have Rob Deal, who's the VP of Healthcare Solutions with Everrise. Hi, Rob.
Hi, how you doing? So I am Vice President of Healthcare Solutions, and what that means is I focus specifically on how Everrise goes to the market for a variety of healthcare clients. These can be payers, providers, they can be pharmacies, pharmaceutical, life science, et cetera. Everrise is a premium outsourced CX provider, customer experience provider. And what we do is we specialize in two very important fields. We specialize in healthcare and we specialize in technology. And this is particularly important in the connected health space because they really do have the intersection of a service mindset and a technology mindset. Many of the offerings may include both a virtual visit service and some component of technology, maybe a clinical monitor. The company offers an omni-channel capability that really lets our clients meet their customers wherever they want to be supported. That could be in voice, chat, video, email, the web. The company has a global footprint, which allows us to offer services onshore, nearshore, and offshore. And that really gives us the flexibility to scale for our clients as their needs change. So, thank you.
Great. You all have a really unique perspective on the kind of the logistics of the rapid scaling of telehealth this year for sure. So thanks for being with us, Rob. Next, we have Mia Finkelstein, who's the Medical Director of Amwell.
Great. Thanks, Jennifer. And I'm happy to be here. I do want to say that I am just in awe of the devices that are being used at Scripps and really all over. And I definitely share Dr. Cook's confidence in the future of telemedicine, as I'm sure everybody here on the panel does as well. So it's really exciting to hear their perspectives. Thank you for that. I am a family physician, and I've been working with Amwell for 9 years now. Amwell is both a tech company as well as a medical group, the Amwell Medical Group. We have over 8,000 clinicians. That includes behavioral health, nutritionists, primary care physicians like myself. And I've been seeing patients virtually for 9 years now. I've seen, I think, close to or maybe over 30,000 visits at this time. So it's really been exciting to see the growth since back in 2012 when I started to now. And of course, you know, during the pandemic, just the escalation. I'm also a medical director and have been one for 6 years. So with that role, I have been able to work with all of our partners, insurance companies, health systems, employer groups in starting new platforms and in trying to take their vision and bring it to fruition. I work closely with mentoring and training our physicians so that we can offer quality standard of care, you know, across the board. But happy to be here.
Wonderful. Thank you, Mia. Thank you for being here as well. And Amwell's been doing this for a long time. So certainly you have that kind of long historical view of how things have changed for sure. Next we have Dr. Prentice Taylor, who's the VP of Medical Affairs for Doctor On Demand.
Hi there. I'm Dr. Prentice Taylor, primary care physician at Doctor On Demand in Grand Rounds Health. Thanks for having me today. Our service was the idea of the TV psychologist, Dr. Phil McGraw, is from the small town of Bonita, Oklahoma. He and his son had the vision of providing high quality health care in all zip codes across the United States. If I can explain Doctor on Demand in one sentence, it is a high-tech national medical and behavioral health practice that pops up in your mobile device 24 hours a day in all 50 states. Virtual primary care is an innovation we started with Humana in 2019, then with Walmart's and Blues plans, and is an innovation that continues to expand. Virtual primary care offers increased rapid access to high-quality dedicated PCPs with short waits for appointments. PCPs are backed up by very short waits with urgent care doctors, 24 hours a day, and behavioral health visits within 7 days with psychiatrists, psychologists, licensed clinical social workers, and health coaches. Grand Rounds Health is our navigation and expert medical opinion service. It's a specialty care service that integrates into the medical and behavioral health services to focus on improving clinician quality and avoiding gaps in care. Doctor on Demand merged with Grand Rounds Health this year to create an end-to-end total virtual care experience. Doctor on Demand is dedicated to being a diverse and inclusive organization. We're committed to advocacy and action to combat racism, discrimination, and inequities in healthcare and technology, and also within our own organization. We've intentionally staffed our teams with full-time employed, diverse clinicians to leverage both the highest quality clinical expertise, both to better design our solutions and to better deliver care to members. So we know that diverse providers allow us to better serve our populations. Our providers average 17 years of experience, over 60% are female, 43% are medical providers who are people of color, 69% are patients, are parents, I meant to say, and 20% of our behavioral health providers are from LGBTQ communities. We provide cultural competency training to improve health equity. Our acquisition of Included Health this year underscores this. Included has been focused for years on helping LGBTQ individuals navigate an often unfriendly in the U.S. nationally. So I want to thank you for allowing me to speak for 3 minutes to share a brief glimpse of how our telehealth landscape is evolving going on through this decade. Thank you.
Wonderful. Thank you, Prentice, and especially for shining the light on the ability to serve underserved communities. And I think that might be a line of discussion that we get into today. Before we actually dive into the discussion, I wanted to bring up the results of a poll that we've had in the poll tab here. For those of you who have are watching, you know, we asked which change in the healthcare landscape has had the biggest impact on increasing virtual care adoption. Increased service scope, improvements to medical licensure regulation, improved reimbursement, increasing consumer awareness and familiarity, and then providers needing to adopt telehealth in order to operate in a COVID-19 environment, which by far and away has 70% of the vote. You know, it really, this incredible scaling of telehealth over the past 18 months has been driven by necessity. So what I'd like to start with on the panel here is, when you look back at the past 18 months, and there was the shutdown of the scaling, and then some normalization, and then there's been surges and vaccination waves, right? Let's start with, what do you see as the biggest successes of the past 18 months? It's a little bit of a whirlwind, but I'd love to start with Mia. You know, if you can talk to us about, you know, what you think the biggest successes in virtual care have been over the past 18 months.
Yeah, well, as we've talked about those survey results, I think what stands out the most to me, I mean, we see that telemedicine has been adopted and the genie's out of the bottle, to requote Dr. Cook. But I think that what stands out to me is that so many people, like over 50% of users, it was their first visit with telemedicine. And once they've tried it, they realize, wow, you know, I don't have to avoid taking care of myself anymore. Family members can breathe a sigh of relief because they're worried about, let's say, their mother who was neglecting to go in because she was afraid of what she might get, what might happen if she was outside. So it's keeping people safe, it's keeping them at home. People are using it for the first time and they're confident, you know, about the care. They're happy with the confidence and that they have in the care that they received. I think that is huge. I also think that just being able to get physicians to also embrace this as a way to provide care. I will say, 9 years ago when I left my practice, people laughed at me. My colleagues laughed at me and they're like, you'll be back, you're still doing that thing. And now they're the ones who are realizing the utility, the benefit, how much it really enhances their practice. They're able to reach out, for instance, I'm in a sort of rural community. They're able to reach out to elder patients who relied, let's say, on family members to bring them into the office. Maybe they lost them to care because they wanted to refer them out of the county and, they don't want to leave the county. So I think seeing the utility finally and physicians embracing it as well as patients, it's just, that's the biggest success in my eyes.
Yeah, absolutely. I mean, that sort of forced familiarity and use of the services certainly doesn't go back into the box. Prentice, I think, is raising his hand there. Then we'll go to Brian. So, go ahead.
Those are wonderful comments that Dr. Finkelstein added. I just like to add on, I think in behavioral health, our experience and that of others has been is it greatly increased the access to private visits with not a lot of red tape and relatively easily for people with behavioral health concerns. We know that anxiety levels and depression levels that were measured increased remarkably in surveys that others did independently during this pandemic. And I anticipate that's going to last, that people love the access to behavioral health, especially when it's integrated with their physical health problems. And I do think that's going to be a lasting benefit to everyone.
I think that's a great point, and actually some of our research in the past has shown that one, especially among younger patients, their ability to access behavioral and mental health services in a more anonymous kind of way than an in-person visit is highly appealing to them.
And Jennifer, if I could just add to that too, it's not even just, I'm urgent care, but it's not even just our BH visits, so scheduled visits that people are coming in on, but even in the urgent care space, we'll have patients come in, with maybe that was about COVID, maybe it was about another diagnosis, but they have anxiety. And they may just start to break down in front of you. Or, we train our physicians, ask, hey, if someone has disclosed they have anxiety or depression or they've shared medications that they're on, ask them, how are you doing? How are you coping with all this? Just to let them know that, we're there for them as they need, to Dr. Taylor's point.
Absolutely.
Yeah, I'll jump in there and first, echo all the points that were just shared. I think this period of what I would call kind of forced pilots has really proven not just that it works, but that virtual care is in many cases just as high a quality care as the in-office alternatives. And I think I'm skipping ahead a little bit to the regulatory side of things, but prior to the pandemic, we saw so many state-based regulations that would kind of relegate virtual health to if you can't get access to the physical facility, then I guess virtual health is a good second option for you. I think that through these forced pilots, there has been so much new data and results generated that are really going to help support proving the value of these technologies. And then the last thing that I would add is the pandemic really also put the physical infrastructure of healthcare, really pushed its envelope, and we started to see across the country as different areas of outbreak would happen, there would be this swarming of the people that had to provide the hands-on care. But what you also saw was virtual health allowed, as we saw outbreaks in those regions, not to have to swarm a lot of resources there. And I think that translates a lot into the regional or the rural versus urban setting type of point that was made a second ago, which is, trying to get adequate specialty care and behavioral health care in every geographical location in the country. There just aren't enough professionals to do that. But by making this available virtually, we can really start to make the resources we have available as efficient as possible by much more broadly making them available.
Yeah, absolutely. And I know Iris wanted to jump in here as well. What successes do you think really come to the forefront when you think about Northwell Health's experience over the last 18 months?
Well, again, similar to my colleagues, it was adoption. I think prior to the pandemic, we were doing a couple of hundred visits in a day. During the pandemic, we jumped to 8,000 visits a day. We took 200 providers and turned that in within about 3 weeks into 7,000 providers that were available. What it did do is allow for a lot of care to be continued and maintain that safety, but it also forced adoption, and now people can't get enough of it. We had a very mature behavioral health program beforehand, and that took off wildly after the pandemic, and it continues to grow, and we do outreach from it. And they're just, I mean, this is one of those shortages that you're talking about across the country. So certainly that has been another piece to it. The other piece, I would say, along with that ability, is to create a community of standardized care, because you can reach beyond boundaries and bring those specialties together through the use of technology. And we were certainly able to both help our colleagues in other areas of the country, and then they in turn were able to help us when we were the first ones that got hit. I don't know if you read about us, but we got hit rather badly, rather upfront, and it was wonderful to be able to reach across the other side of the country. And because of the time change and the technology, to not have a break in that continuity of care on the acute care side as well. So it bridged that gap across the entire continuum. And now that remains part of what we explore as we continue to grow our programs.
Well, so Iris, real quick back to you, and then I'll be going to Rob. So let's think about the other side of it too, right? So there have been, again, kind of phenomenal successes that I certainly don't want to underplay at all. The kind of heroic efforts that has had to happen from all the teams behind the scenes to make this work. What would you say are the issues? What hasn't worked, right? What issues are really right, ahead of you to solve, in the next 18 months?
Yeah, I mean, I think one of the things we've learned is there's a lot of interoperability issues. We also know that there's a lot of people that don't have access to good, reliable broadband. And if we don't solve for that, we are going to have a very large problem. We're going to create a larger divide. And we certainly saw that in the urban and the rural areas. I really like to get away from that terminology of rural versus urban and just call it underserved. And we have a good number of people in this country that are underserved. And if we don't fix that, telehealth will create this chasm again. So I think that was one of the biggest highlights of the COVID emergency, which continues to happen.
Absolutely. Rob, to you, what are your thoughts on, what issues really remain the most urgent to solve in the virtual care space?
Yeah, I would say that when it all works great, it's great. Unfortunately, it doesn't. It's funny, just an hour ago, my son was having a virtual visit with his physician, and it was as simple as scheduling a Zoom call, and they got on and talked. The first time he did that, we didn't get the Zoom meeting. I didn't know who to call. I ended up calling the front desk, and they're like, well, you should have gotten it. And they weren't able to really respond and handle the situation very well. Now we sort of, over the periods of times that he's had these visits, we've figured out the process. But I think that it's very important when these types of solutions are being developed that you've got to remember you're integrating not just the service component, but potentially technology as well. If there's any kind of a monitoring device, or even just being able to run a Zoom call, there's a lot of people that, even if they have broadband, may not know how to do it. And the last thing that I would want to have happen is that a physician, with their very valuable time, get ready to get on a call to do a visit with a patient, and there's some sort of a technological hiccup. Patient doesn't know what they're doing, the email didn't go out, whatever that may be. So I think it's really important, as these programs are continuing to develop, that you don't lose sight of the support side. I don't want a doctor, trying to diagnose the problem of why the microphone isn't working on my PC. That's a waste of their time. And one of the ways I think to solve that is, certainly for that first visit, you have a more enhanced sort of a concierge or a white glove service where you go through the process with the patient or the member or the consumer, so that they get familiar with exactly how this is going to work. It may be how to connect up a device. I've got to connect a thing to a router to a what, there's a lot of, especially the elderly population, that may not really be comfortable with that. So let's walk them through that process so that everything is working. Make sure that if there is a problem, there's a clear line of communication who to go to. and then make sure that person who's helping solve the problem can both solve the sort of consumer side of the issues and the technology side. And I think that will add a level of maturity to a lot of these services that right now we're still in an early stage, and we're so excited we can do it some of the time, most of the time, but not all of the time. And that certainly impacts the adoption and the consumer experience, and can really frustrate the physicians and the clinicians when it isn't working and they're like, my time is valuable. So anyway, that would be my thought.
Yeah, absolutely. Thanks for sharing that. It does speak to, of course, consumers are different, and some people love tech, some people hate tech, some people, love to engage in technology and services in different ways throughout their lives and have different, levels of need for support. One of the major limitations, I'm coming to Prentice and Brian here, of standard sort of virtual care visits today is, the lack of real-time quality data that you're used to accessing when you're in the facility, when I'm thinking about vital signs, right? Or weight or just temperature. So that gets in a little bit to the role of potentially devices in a virtual care setting. So I'm interested in understanding, Prentice, to start with you, your perspective on the role of connected health devices in the larger virtual care, model, and how that's going to play out over time.
Well, we've been using connected devices for 2 or 3 years very actively within virtual primary care, and to a somewhat more limited extent within our urgent care practice, to measure blood pressures, for instance, and double check glucoses and that type of thing. But, the connected word for me is a little bit loaded. Bluetooth devices are ideal in some ways, but those are more expensive, and that's off-putting for a lot of patients, particularly if they come from a lower income background or, so-called working class background like my parents are from. I'm thinking back, interestingly, since we have Validic on the call, prior to the pandemic, I saw a demo of Validic's capabilities of being able to ingest data from a variety of device screens. I thought that was very interesting. But I would just say that, speaking for us, that we've found we can function very well with the devices that are already out there. It's just more making sure people have reliable devices like the Heart Association AMA recommended, Consumer Reports recommended blood pressure cuffs. So those blood pressure devices. So I'll stop there.
Well, I'd love to just follow up real quick, and then certainly hear Brian's perspective from the Validic integration point of view. From a doctor's perspective, is there any value in any more value in standard blood pressure type monitor that somebody might have at home, and during a visit with a doctor on doctor demand, they can, show them what the reading was, versus something that's maybe more automated? Are there any questions in the provider mind as to, are these patients using them properly in the home? Are the readings accurate, right? How much trust do providers have in the device readings at the home setting?
If I could comment very briefly, the American Heart Association has a lot of standards they put out about home blood pressure. And so what we do is we ship a video clip to patients with the blood pressure device. So it's both a high quality, standardized, automated device, and they get a video orientation on how to use it properly with American Heart Association technique.
That's smart. Brian, to you, tell us what you think are the best opportunities right now for integrating the devices, right, that can give us a little bit more data, and that could potentially expand beyond the limits of virtual care services right now. What's Validic doing, and what's kind of the next step there?
Yeah, the first thing I'll say, maybe surprising for the Validic guy to say on the call, but I actually agree with Prentice that in a live video visit with your physician, if you have a blood pressure cuff, connected or not, taking your blood pressure and just telling the doctor what the doctor said or showing them on the screen, that's probably a perfectly fine workflow for that specific use case. I think that is probably something that we've really accelerated our learning, is that for different use cases, there are different approaches that are going to be most appropriate. So, a set of connected Bluetooth or cellular connected devices for ongoing chronic condition monitoring or post-acute surveillance, or a use case that Validic was really proud to support during the first major peak of COVID. We had an organization on the health system on the East Coast who they were at full capacity, and they had a number of COVID positive patients that they said, if we were at lower capacity, we'd probably be admitting these people, but we're just not going to be able to do that, and sent them home with pulse oximeters, blood pressure cuffs, and thermometers. And there were a number, and then they monitored them. The ones that really needed that acute space, they were able to bring back into the hospital. And they told us that without any exaggeration, they felt like there were dozens, if not hundreds of people that were still alive today because they were able to monitor that. Trying to do that with self-reporting or calling that in on the phone on a regular basis, that would be really challenging for a population at that scale. So, when we're talking about chronic condition monitoring, post-acute monitoring, another use case, we had a conversation with a cardiologist recently. When you prescribe a new medication that requires some level of titration, being able to take those readings on an ongoing basis and get the output from those things that, for example, if we're trying to treat a patient with AFib and titrate the medications to get them back to a normal rhythm, I want you to take that med that night, and then the next morning I want you to check back in with your heart rate or your EKG. Those are the types of use cases that we really think a ecosystem of connected devices makes a lot of sense. And then you want to think about all of the different types of people in your population. A high availability, high reliability, high cost prepackage with a cellular data plan, that would be very expensive for a newly diagnosed diabetic that's just trying to learn about their condition. That is an extremely appropriate solve for somebody who just got discharged after a heart failure exacerbation. So being able to support everything from bring your own device to a fully ready to go kit and everything in between, like different use cases have different solves.
So some of our survey data from this year has shown this incredible growth in use and consumers going out and getting health devices on their own, a category like a pulse ox and consumers were not paying attention to before the pandemic. They know what it is now, they know what it does, they know what blood oxygen is about. Are you seeing that same kind of surge in device adoption from your kind of behind the scenes look and the data coming in from the various devices?
We definitely are. As you would expect, one data trend that we saw was physical activity has kind of dropped off during the pandemic as a lot of people's commutes have gotten a lot shorter and things like that. But yeah, the biggest growth areas of device usage and sustained device usage, I think, is probably an important thing to talk about also, is on more of those clinical metrics. Obviously, people concerned about COVID-19 are buying pulse oximeters and checking that on a regular basis. I don't expect that data area to continue to sustain as hopefully we find the end of the pandemic at some point. But things like checking in on your blood pressure, checking in on your blood glucose, other clinical metrics, that is where people are really starting to dig in. The market growth on wellness and activity type devices, it's kind of flat and maybe a little 2%, 5% growing year over year, but the clinical side of things is where we're seeing the double-digit growth. Yeah,
interesting. So let me turn to Iris and then Mia on the idea that, obviously we talk a lot about technology here at Connected Health Summit, but there is a very valid and needed role for the human practitioner in many cases. So one of the things that distinguishes hospital at home models from something like remote patient monitoring or trying to put the dividing lines around these kind of buckets of virtual care is that idea that somebody may be coming into the home, to do measurements or for setup of devices perhaps. Iris, first to you, could you talk to us about what you see as the opportunity for some models that maybe blends actual humans into the home, human practitioners into the home, when we think about shifting away from the facility, maybe into more home care?
Yeah, I think there's a lot of opportunities there, not just for hospital home, but even things like we have a telelactation program. When you start integrating things like chatbots, which can connect when it's necessary for a provider to then complement what they're getting through their technology, a lot like what Brian was just saying. You know, there's some things that'll be more integrated than others. Some are for during the visit, but some are based on a trend, and having the ability to connect back into a provider, to a patient home with a really good workflow that has a decision tree, if you will, built into it, along with the technology and the human touch, is really key to the success of that. Because at the end of the day, technology is only going to do so much. And at some point, if there needs to be an intervention, that needs to have that workflow and the availability of a human to help with the final pieces of that care plan. And we've seen a lot of good success with that. We have a really successful program that actually was done through our program Health Solutions before Health at Home, before the Hospital at Home was suggested. And so we were ready to start with that, and it worked really well. We had something called the Crown Program when we reached max and had to keep people at home, where they connected in with their pulmonologist when necessary, based on readings and decision trees that were provided for them. So it was really a tight workflow that was able to pull all of that together.
You know, we actually got a question in from the audience here that might speak to workflow issues a little bit. So the question is, you know, how are telehealth encounters documented, especially in urgent care models? Does the patient's healthcare provider or health system receive an encounter document? And how does a system like Northwell handle, you know, that type of workflow, right?
So interestingly enough, we were starting, this was one of those silver linings. We knew that we had to start creating this before the pandemic. And overnight, we had to make it happen. And it was the best thing we ever did, because from a billing standpoint, it allowed us to be able to find those notes and to associate the visit with the bill that was dropped and make sure we were compliant. But yes, we document into the EMR. And then, of course, there's the HIE, which helped us tremendously in New York State to connect for patients that were unknown or new to Northwell and may have had past history. That's still not where it needs to be. I would say if we wanted to ever ask for anything as a national EMR, if we could ever get there, I don't know if that will happen in my lifetime. I sure hope it will. But it was interesting because when we were in Javits Center, we noticed the discourse and the problem with getting information to take care of patients that were known to Northwell and unknown to Northwell. And that was a challenge. We had to go back to old-fashioned paper because we didn't have a national EMR, but we were able, for a good number of those patients who had sought medical care, you know, in the past, in the state of New York, we were able to pull information and put together a pretty good picture.
Really? Please go ahead.
That's it. So EMRs are the way to go, but we need a good one.
Yeah. Well, so Mia, I'd love to turn to you from the Amwell perspective as well, right? Amwell's kind of behind the scenes and in front of the patient as well, right? And all sorts of different partnerships. If you could speak to a little bit about how the telehealth encounters, you know, that are coming through your system, you know, work into your partner systems, but also this idea of, you know, where are there opportunities for devices and kind of human practitioners to supplement that virtual visit?
Mm-hmm. Yeah, I think we're all seeing recognition growing that the future of care is going to bring this hybrid model together. You know, the in-person, the virtual, automated care interactions, devices, et cetera. And I will add just something that was mentioned earlier. I have been impressed. Granted, there are still many underserved areas, to Iris's point, and I know we have to reach to them, and that's really the solution we need to have in the future. But I have been impressed with how many elderly patients do have devices, you know, whether it's a blood pressure monitor that I have them check in front of me, or they may have an Apple Watch or another type of watch where they can upload some of their own personal data. blood work that they've received from their primary care physician. So it really is excellent to see the understanding on their part that they'll sort of preload that information. Of course, it's self-reported right now for us, but I do like that. And then, of course, we have our own EMR. So to the question about, documentation, we have, templates. We train our providers so that everyone has pretty much a standard process going on, but we let physicians be physicians, and each visit is different, of course. Trying to underscore the importance of a primary care physician, and getting them back in the office when they need to, but also educating them as to understanding, what you can do safely through a telemedicine visit with or without devices, et cetera. So, that's exciting. But I think I wanted to bring up how during the pandemic, Nemours, which is one of our partners, launched a tele-well visit for children, which, was really such a wonderful thing to hear about. But much of the visit, takes place online. Families will drive by for necessary hands-on components like child vaccinations, but the provider can go through anticipatory guidance, talk to the parents and the child, do some, some minor examination, have them do some of their, standing on one leg, jumping, et cetera, just to see their gross motor and order those vaccinations. So this model really helped Nemours achieve the same rate of children's well visits as the year prior to June 2020. So that was really wonderful for them. And, immunizations for children are so important. I think I answered the question there.
Yeah, that's such a great example too, because there are ways that you think in a legacy mindset. Well, of course, that well visit has to happen in person because the doctor needs to see all this. Well, you're forced to do it a different way, so you do it a different way. So that's a great example.
Yeah, and when we train our providers, again, creativity really is, I know we're all doing telemedicine, so we all know about that, but you can get so much from a history, and you can convey empathy and compassion when you speak to someone who's struggling or who is uncomfortable, whether it's COVID or not. But, you really can get creative with some of the examination things you can do. And that's really been kind of fun and a challenge at the same time. So the devices will just, the things that Scripps are doing, that is just incredible. It's going to make it so much easier as we can start to adopt these things and, have one national EMR one day.
Well, and there's one thing I wanted to follow up too on what you were saying about, how impressed you've been with some older consumers that we may have underestimated their ability, right, to engage in virtual care. So, you have this great perspective of kind of pre-pandemic to now on telehealth users, right? And early on, at least in Park Associates data, we had 9%, and then in 2018, and I think 15% in 2019, people using telehealth services on their own before COVID hit. Well, most of them were sort of younger, maybe households with children that couldn't get to a doctor's office and doctor's hours, and so there was sort of a convenience element, but also early tech adopters, right? People who are sort of innovators or early adopters and not really mass market consumers. Well, now that's expanded dramatically. We're kind of mass market at this point. So can you share any learnings or insights you've seen on what that means when you're serving a very different, type of consumer, right? Or, the opportunities or challenges it presents for different kind of customer segments. People are different,
Yeah, well, I think just to the elderly part, just for me in particular, and I wish I don't have numbers to give you or to present right now, but I have a lot of the southern states. So in the winter, a lot of snowbirds will go south. And I just remember each year seeing those southern states increase with visits over the age of 60. And I worked overnight last night, and I had 5 patients in their 70s. So it really is happening in front of our eyes that whether family members have set up accounts for family members, who are elderly, or they're doing it on their own. Let's face it, to other points have been made. Your phone is with you or your iPad is with you. You might be near a computer. People are getting more comfortable using these things as long as we can solve for them getting those technologies. And I think the other point that you made, historically, telemedicine visits, at least for me, have really just been urgent care visits, but there was a great increase in specialty care during the pandemic, continues, but certainly during the last 18 months, where patients are not just coming in for urgent care, but they're scheduling, whether it's with their primary care physician or more importantly more importantly with specialists. And I think that really stands out, that specialty care is using this and will continue to.
Absolutely. Prentice, I know you wanted to jump in here.
I was just going to add that, seniors fall into different categories. And if I can generalize, I would say there are seniors who maybe fit your profile of the early adopters who are very savvy about a lot of things. There are other seniors who are sometimes correlate with rising risks of turning towards multi-morbidity, who maybe are not as familiar with the technologies, but they'd like to do it. And then there's the frail elderly. So in our experience, we find that seniors, particularly if they've had a relative or somebody who's tech savvy, who's a niece or a neighbor, show them how to do the first visit, they can fly very well thereafter. In fact, I would say that we were astounded in our practice that our oldest patient calling in totally independently was a 93-year-old man who was very savvy. So the thing I would say finally is that for that frail elderly group, at least in my own mind personally, that's where the hospital at home programs can be very useful in having a caretaker help with onboarding and maybe continued assistance with telehealth visits.
Yeah, absolutely. That makes a lot of sense. Go ahead, Brian.
Yeah, I just because it's so timely, I'll share this story. And if you saw me looking off my screen for a minute, it's because it's happening in real time. I have a 95-year-old family member who is needing to get some specialty medical attention. She went into an appointment today, and she lives 800 miles away from me, and my dad went with her. And at the end of the visit, they were like, "Why did we have to come in? You didn't even touch me or measure anything on me." And the reason that they asked that is for her to get to that specialty clinic, there's a bus that we have to get, a duty nurse to go with her. It is a whole production. And, if there are readings that we need to take or tests that we need to run, then yeah, it's worth that effort. But to literally do all of that to sit and have a meeting, like there are better approaches.
Yeah, thank you for sharing that example. And actually, we recently had a podcast episode, Parks as a podcast, Connected Consumer. And our guest speaker was Brooke McCall, who is with United Spinal and herself is a high-level quadriplegic. And she said, when we asked her about her own impact in her own life in telehealth, and she said, there are so many visits. I need care, of course. There's so many visits I have that I'm never touched, and I'm never brought out of my chair. And the life change it is to not have to go in for all the visits where I'm not going to have that hands-on. So much can be done by sight and by talk, right? And really changes her experience with the healthcare system in a great way. Iris?
Yeah, I was going to tell you a story too. It's not just for the elderly either. I mean, we had a sick kid just before the pandemic started, and they were vent dependent at home. And every time the kid had to go to a different specialist, the mom had to take off from work, arrange for an ambulance and an attendant to go with them. One day we tried using telehealth because we were able to use the multi-parties, and we pulled in the primary care doctor, the pulmonologist, the nutritionist, and the occupational therapist on one meeting. And we had a multidisciplinary meeting in one sitting. She never had to leave her house. She got all of her answers for her child. I mean, how great is that? But now you have the problem of, well, do we all get reimbursed? Because CMS hasn't gotten there yet. For our and we need to start working on sharing these kinds of stories because it does happen.
That actually segment's great to a question that we got from the audience. So, I mean, that is doing the right thing for the patient, right? But there's legacy models of healthcare, right, that maybe make that not as common an experience. So one of the questions we had is, let's see, that one right there, yeah. The other one. So how much savings are being realized for doctors, and how are healthcare systems able to show the investment in technology eventually will save money? So, right, there's the business side of this. The technology was really ready pretty much, before this hit. And then there was sort of the training of providers and staff and resources to make it all roll out. Well, what about the kind of money side, and how is that going to look long term? Does anybody want to jump in on that?
So I think part of the problem, ROI, there's a lot of qualitative and there's a lot of variables in healthcare. It's never just one thing that's impacting an outcome. So it's what outcomes are you going to measure? In the case of acute care, it could be hospital length of stay, but there's other things that impact that besides whether we expedite care. But I mean, we already know from years back, and the reason that telestroke is reimbursed by CMS now, and they do some for at-home care for end-stage renal disease dialysis patients, is because they have enough data now to say this actually saved money and it was good for the patient and we had good outcomes. We need to start pulling together and looking at this maybe by diagnosis. And there are some organizations that are about to submit information from larger health systems. Several of us have contributed from our claims data to start looking at where, and there's some surprising things I think we're going to find out. We haven't gotten the results yet, but that should be more publicized by the end of September. And I really think we have to all be really concerted and look at some data definitions so we're all measuring the same things, and then we'll be able to prove our ROI. But right now it's tough. It's not that easy because we're still early in it.
Yeah, I think Brian made the point earlier that essentially this forced trial and forced rollout, right, is really bringing in mountains of data that hopefully can be used to prove the value, but a lot of that work still needs to be done. Rob?
Yeah, I would also say that while there's sort of the ROI business side of it, we sometimes lose sight to the quality of life, the expansion of care. There's a lot of sort of non-tangible, at least dollar-wise, benefits on the patient side and on the facility side that we tend to forget because we try to go to that financial model that just says, okay, pay me this, I get that. And I think that we're really not doing a service if we don't try to include that in. It may be harder to quantify, but it's really probably one of the better benefits that we're getting out of this is that expansion of care, people willing to go to the doctor, able to do it. They don't have to take the bus. They don't have to take off from work. It's going to actually move care further up, not to the catastrophic end, but more to the wellness side. So overall, save us a lot of money down the road. So I'd add that.
Yeah, absolutely. Thank you. So I want to remind all of the attendees today to submit any additional questions that you have. We have about 10 minutes left, and I see a few others that have come in. So if there are any other questions, now's your moment. So the next question I'm going to throw to Rob and then back to Prentice. But when we think about the future of the market, there's just still so much uncertainty here. We're still in the middle of the pandemic and in the middle of another surge, right? The way that vaccination rollout and uptake maybe was predicted to happen has been slower or lower than expected. When you're thinking about this moment as a business, how do you plan in this type of environment, right? How do you look to your next steps and kind of know where to go? And Rob, I'll come back to you on that.
Sure. I think that, as I look down the road, I see a couple of things that are going to happen that we haven't gotten to yet. Number one, we'll figure out how to get connected devices connected and providing data, which I think is a key component, because right now, if you don't have the ability to get all that data, it's going to drive a lot more visits, or there will be some location that you go to just to get your measurements done and then you go back home. We'll come up with some method for that. But I think the area that I'm more worried about or think that there's going to be more challenges is the proliferation of the consumer purchase devices generating a lot of data that then is it worthless? Is it valuable? There's sort of that signal in the noise concept of we'll get a lot of information. What's actually of value? What isn't? Are the machines calibrated? Are we going to have a drift? Do we have some sort of ability to know and believe that the data that we're receiving is actually valid, clinically valid? I think there's a lot of those issues, that eventually we'll get into the whole analytics side. We talked about if we just had a model that could, tell me what's going on, and we haven't gotten there yet. You can build the models, but actually implementing them into workflow is incredibly difficult to do. How do we get that message out? So I think there's a lot of infrastructure and systems that still need to be developed that will, expand this service and make it beyond just sort of the virtual visit, how are you doing, things that I can do without having to touch you. there's no reason why our technologies won't give us the ability to capture a lot of relevant data as long as we trust it, know that it's being captured correctly, and then the physician can leverage that, or the clinician can leverage that as part of the care plan. So that's the areas that I'm looking down the road. I think it may be a little further down, but we're definitely going to bump up against that, and we should be thinking about that now. I've heard a lot of it's self-reported, and it's like at some point in time we got to get beyond self-reported. We have to actually believe what's coming in. So how do we do that? And that's probably the thing that I'm looking at mostly, as we go down the road.
Great. Prentice, to you, said I was coming to you next. So, how is Doctor on Demand sort of planning its next steps?
Well, what I can say publicly is that, what we are really focused on is the fact that people have to navigate a fragmented healthcare system if they have any kind of problem, whether it's a very complex one or a slightly complex one. And it's all DIY, do it yourself for the most part. The other problem is that a lot of employers and health plans have all these point source solutions. There are many companies that have 8 to 12 point source solutions that are not integrated, not collected. And again, it's a maze that people have to go through on their employee benefits website. So we have created an end-to-end solution that combines the navigation strengths over 8 years from our Grand Rounds Health capacities with state-of-the-art telemedicine, integrated behavioral health, and having all of that flow together so that it can create ability to solve any number of problems, like how you understand your benefits, what happens if you have a denial from your insurance provider, how do you appeal? We think this is a way that it's going to really help people, and where devices at the periphery can assist with some of that, that's great. But I wouldn't say that our core focus is on devices at this moment.
Yeah. Well, we did have a question from the audience, so I'll go right back to you with this question. How effective are your telehealth services for rural areas? Can you talk at all about, sort of the rural population and Doctor on Demand's services? Go ahead.
Yeah, I would say that we have a study that we published in the Journal of Medical Internet Research. It's probably not as widely read as some others, but basically we found that during the pandemic, 42% of our visits were from rural and small town zip codes, which was very pleasing in terms of our heritage, having started with that focus. So, and we also looked at lower income zip codes, and we are pleased that we're reaching into that. Now, some of that may be partly because Walmart and Humana are some of our biggest partners. I can say that publicly, and they have that focus. So that may be part of why, we have a slant towards that. But we want to continue that. We want to serve with equity across all zip codes in the United States.
Great, thank you. Iris, we have another question that I'm going to direct to you from the audience around how training for providers has changed now, versus prior to the pandemic. So how are you getting your providers on board, especially with virtual care training?
Well, one of the things that's happened, actually, and I'll confess that it was kind of a free-for-all before this, but now it's much more formalized. We've used technology to leverage some of the training, and we have people that are accountable in each of our regions to help with extending that training. So we combine it with a little bit of simulation and some mocks before we release a program. And each of our specialties has a meeting. We have a program team. We always did, but we've extended it to the ambulatory side as well. So it was primarily focused on the acute care side in the early years. And now we have a complete project and program team, and we focus on quality initiatives along with that. We create a charter, and we make sure that the people attend, and they can't unless there's been 80% trained within a given service line or practice or a particular program before we can let them launch it, so that we're assured of a little bit more compliance with certain workflows that we know are proven workflows that will improve the reliability of the experience, both for the provider and the patient. And so, they've adopted to that pretty well.
Great, thank you. And I actually might also invite Rob to speak to this a little bit. I know that you talked earlier about this kind of white glove service to help the end customer, the end user in using, the services and the virtual care services. How about the opportunity to support doctors and providers?
Yeah, sort of what I would say the B2B side, because they're more the business than the consumer side. But yes, you know, the ability to support the professionals, it's just a slightly different level of training. And usually you don't have to train as many. You know, you'll have a lot of patients and you'll have a limited set of physicians. But their understanding and ability to, you know, accurately work within the environment is, you know, one well-trained physician is worth, you know, 100 well-trained patients, kind of thing. So it's definitely worth the effort. You've got to meet the physician or the clinician where they're at. So it is important that, you know, they're bright people. So you don't have to necessarily start back at the beginning, though. You know, sometimes you do. But it is to offer that training for both, you know, both for the patient side and the professionals, and also to be able to support the professionals. They don't want to do support issues. They don't want to do it. And I don't blame them. Their time's valuable. So let's put in place the program that allows that to not be an issue, or rarely, or if it happens, they know who to pull in right away to help while they're working at the top of their license, not trying to be a computer repairman. So,
yeah, I do think that, you know, the wrapping of professional services around virtual care almost shows the maturity and where, right, these services are getting to. That'll have to be our last word. Thank you, all of you, for your wonderful insights today and for your time. Very much appreciate it. We also want to thank our sponsors, Alarm.com, Essence, and Everise, for your support. There's some more information on alarm.com, as well as in the attendee platform there, if you're interested in learning more about their enterprise wellness solutions. I also like to take a moment to mention Park Associates' upcoming connected health research. So I mentioned the survey that we conducted in April, and those results are publishing. And so we have one that focuses specifically on virtual care services and devices and bringing the voice of the consumer to bear, as well as a focus on healthy and well living at home with senior assistive technology. We have a market report that's looking at the state of the connected health market coming out later this year, as well as looking at the smartwatch market specifically. So if you're interested in any of that research, please contact our sales team. We are offering a $500 credit to any of our Connected Health Summit attendees for a sort of September special. So if you're interested in any of that great research coming out, please contact Jason Paris, and he's happy to extend you that credit. So from here, we are going to break out into our networking discussion. Our team will have posted a link to the networking chat for you to follow, and we hope to see you all in that discussion. And then we'll be back here at 2 o'clock Central Time. From 2 to 4:15, we'll be focusing on connected health business models. So we'll be back in the swap card platform at 2 o'clock, but hope to see you over in the networking discussion just now. Thanks very much.